Good evening, doctors. Welcome to the Neuroendoscopic Society of India monthly webinar series 7. Wish you a very happy Valentine Day. In spite of such a busy day, you have taken some time out to attend this webinar. From HealthCare, we are very happy to carry this webinar. Today's topics are endoscopic approach to CVJ and anterior cervical technical issues, expanding the horizon of neuroendoscopy, the potential of flexible endoscopy in brain and spine. This is a digital initiative by Health and You, always together, a joint venture with Newlink Company Limited, Japan. Our vision is to fulfill unmet medical needs by launching innovative first-time in India products. We were the first one to launch amitriptyline plus mecobalamin combination AmNurite 5, 10, and 25 for pain relief, feeling good in neuropathic pain and in migraine. We were the first one to combine amitriptyline plus propranolol combination if one is not good enough in migraine. AmNurite beta 520 ER and 1040 ER, which gives compliance to the patient and therefore outcomes are much better. We were the first one to give you pharmacological combination for neuropathic pain of two neuroanalyses put together, amitriptyline and pregabalin given in sustained release form to match pharmacokinetic profile, AmNurite P. Our mecobalamin injections are imported from Japan, Nurite injection for neuropathic pain. We were the first one to introduce 2.5 milligram of clobazam. Our brand is AdClobaz 2.5, 5, and 10 mouth dissolving tablets. Add flexibility, add control in your epilepsy control. Recently, we launched a new concept in migraine, vitamin therapy for migraine, Prentamine. This therapy is proposed by American Academy of Neurology and American Headache Society. So Prentamine is available for migraine. You can prescribe with the conventional therapy in school-going children, even in pregnant ladies. And the most awaited molecule which you wanted to write but could not because of high price, now will be available to common man. We are about to launch Brevaracetam, Brinda. She is soft-spoken and she is coming to meet you. We have this resource that is getting generated on our DigiNeuro channel on YouTube. We have more than 50 plus neurosurgery webinars available here, and more than 500 doctors have already subscribed to this channel. So please subscribe to this channel DigiNeuro, and you can get updates of the forthcoming webinars, and a huge neurosurgery resource is getting generated here, and thanks to also Endoscopic Society of India. So now I have pleasure in asking Professor Suresh Sankhala, who has started this concept, and through Neuroscopic Endoscopic Society of India. He is a consultant neurosurgeon Mumbai. He is the president Neuroendoscopic Society, past president of Indian Society for Pediatric Neurosurgery, past president of Indian Society of Neuro-Oncology. Sir has been past president for Skull-Based Surgery Society of India, past president of Bombay Neurosciences Association, chairman Commercial Asian Australian Society for Pediatric Neurosurgery, and on executive board of International Federation of Neuroendoscopy. So Professor Suresh Sankhala, thank you for having this concept and doing this webinar. This is the 7th in the series. He will be supported by Professor Ashis Pathak. Sir is the Director of Neurosurgery, Fortis Hospital, Mohali, Chandigarh, former Professor of Neurosurgery from prestigious institute, PGI, Chandigarh, former Consultant Pediatric Neurosurgeon, NHS UK, Sheffield, former Lead Vascular, Lead and Skull-Based Neurosurgeon, NHS UK, Kingston, past President of Cerebrovascular Society of India, Honorary Secretary, Neuroendoscopic Society of India, former Honorary EC Member, Indian Society of Pediatric Neurosurgery, and former Honorary EC Member of Indian Society of Neuro-Oncology. So Professor Ashish Pathak and Professor Suresh Sankhala, I have pleasure to hand over this session to you to carry it forward. Thank you very much.
Thank you. Thank you, Mr. Naik. Ashish, please let us start this.
Thank you. Thank you once again. It's a great pleasure for me to be part of this Neuroendoscopic Society monthly webinar, and this is the 7th webinar in the series. And I think we have covered a lot. There might be still few subjects remaining. First of all, I have to thank the president who conceptualized this meeting, Dr. Suresh Sankhala. And I'd been very happy to be a part of it and be instrumental in trying to take it through. Today, we have got 3 important topics by 3 eminent speakers, and each are giants in their fields. The first one is endoscopic approaches to CV junction and anterior cervical spine technical issues, which has been sort of developed and conceptualized by none other than Professor R Yadav, who is the head of the department and director of neurosciences at Netaji Subhash Chandra Bose Medical College at Jabalpur. The second topic is expanding horizons of neuroendoscopy, which would be quite a wide coverage of many newer techniques by none other than Professor P. Sarat Chandra, who is professor at All India Institute of Medical Sciences at New Delhi. Third, but equally important and very interesting topic is the potentials of flexible neuroendoscopy in brain and spine surgery. This is by Professor Alberto Feletti, who is from the Department of Neurosciences, Biomedicine in Movement Sciences, the University of Verona, Italy. We have got eminent panelists today who are very much experts in this field as well. And they would be conducting the meeting, I think, and add much more flavor to the whole discussion. First of all is Professor Daljit Singh, who is Director Professor and Head of Neurosurgery at GB Pant Hospital, New Delhi. He is the Chairman, Bureau of Indian Standards, MHD7 Neurosurgery. He has got more than 200 publications in index journals. He is a BC Rai awardee. He is Treasurer of Neurological Society of India. He is the President-elect of Cerebrovascular Society of India, and he is a past President of Delhi Neurological Association. So I'm sure Dr. Daljit Singh will have great contribution in this meeting. The second person, unfortunately, won't be able to attend, but this is Professor Vernon Velho, who is a professor and head of Grant Medical College. Unfortunately, he is down with COVID. But however, he is a well-known person in this field. He has more than 110 publications in the index journals. He was a fellow of the microneurosurgery training in Fujita University in Japan. He has got innumerable presentations. He has organized workshops, conferences, seminars, meetings, but we'll miss him. And we wish him all the best for speedy recovery from the COVID that he's suffering from. The third person is again a giant in his own capacity, is Professor Ashish Suri of All India Institute of Medical Sciences. He is head of the Unit 2 of the Department of Neurosurgery there. He is not only Professor of Neurosurgery at All India Institute, he is also Adjunct Professor of Indian Institute of Technology at Delhi. And he has been instrumental in setting up an internationally renowned center for training of the young neurosurgeons in microsurgical techniques and other simulation and other things. His interests are in skull-based surgery, neuroendoscopy, cerebrovascular surgery, epilepsy surgery. So he has got immense publications in his field, and his research interests are really very interesting. It is on neurosurgery of simulation, neuroengineering, and neuro-oncology. Welcome, Professor Ashish Suri. Last but not the least is young dynamic Dr. Vikram Karmarkar, who is very much into the field of neuroendoscopy. He is the consultant neurosurgeon at Bombay Hospital Institute of Medical Sciences in Mumbai. He is the past consultant neurosurgeon at National Institute of Neuroscience in Kolkata. He has got huge number of publications in books and journals. His interests are skull-based cerebrovascular surgery, neuroendoscopy. He has conducted several meetings and conferences. This introduction, I also invite all the members of the Neuroendoscopy Society of India and also the non-members, and probably there might be some foreign who are participating in this, to come join us and enrich themselves from this academic feast. With this, I take the permission of the President to introduce the first speaker, who is Professor R Yadav. I think introducing Professor R Yadav in the field of neuroendoscopy in India is something which doesn't need an extra effort, but even then it's a ritual now to introduce him in this meeting. It's a pleasure for anybody or any department to see the students surpass and excel, and Professor Yadav is an example of that. He was trained from Postgraduate Institute of Medical Education and Research, Chandigarh. From there, he started a department from the scratch at Jabalpur, where nothing existed, and single-handedly he set up a department and developed. And now he has got a state-of-art department, which is the center of excellence in the province, with a super specialty hospital, and he is the director of that hospital now. He has been instrumental in developing interest as well as the charm in neuroendoscopy in the country. And way back several years ago, he started his own training system of training young neurosurgeons in cadavers. And they came in batches, and then they now go in hundreds. I think more near about 600 trainees have attended his neuroendoscopy workshop on cadavers and hands-on training, from where they get a proper certificate. So a lot of young neurosurgeons now, if they have learned neuroendoscopy, the effort goes to Professor R Yadav to develop the interest for the younger generation in this country. He has traveled in different centers, delivered lectures, conducted workshops. He has got 79 peer-reviewed articles dedicated to neuroendoscopy. You can see the immense amount of contribution that he has. So out of 134 publications, 79 are on neuroendoscopy only, which speaks volumes about his interest and dedication in the field. More or less, he has also contributed 32 chapters on neuroendoscopy itself in various books. And the latest book is really amazing. Not only that, he has devised new techniques and improvised equipments. The most interesting one is an inexpensive tubular system where you can reach to the depth of the brain using that same tube, which costs rupees 10 in the Indian standards. And you can see how interesting it is. He has also developed semicircular retractor for chronic subdural hematomas. His innovations are not only limited to these two aspects, he has also devised the endoscopic partial corpectomy in cervical spine, endoscopic single stage transoral decompression and fusion in atlantoaxial dislocation, and you'll hear much about it today. He has described new surgical techniques to avoid blind areas in endoscopic surgery, anterior endoscopic techniques for cervical myelopathy, modification of techniques of water jet injection in endoscopic third ventricular, and so on. So I don't want to come between the speaker and the audience. May I now request Professor R Yadav to start his talk, please.
Thank you, sir. This is coming. Next system preference, and then what do we do? Grant permission. Zoom. I think Zoom now. Quit and reopen.
लीव करना पड़ेगा.
If Dr. Yadav's presentation is still not really opening up, then we can request Sarat to start his, and someone can help Dr. Yadav to get his presentation.
No, he's got it.
He's got it.
Yeah, something you can see on the screen now.
He's got his able daughter now. So
That's right.
That's it.
That's good.
Well done.
We can see your screen, Dr. Yadav.
Are you able to see?
Yes, sir. We can see your screen, sir.
Okay.
I can
So,
go.
See your slide.
You can go ahead, sir. You can go ahead now.
okay. So I'm sorry for the problems. I'm thankful to the Neuroendoscopy Society of India for giving me this opportunity. And I am grateful to Professor Ashis Pathak, sir, my teacher, my mentor, for kind word. It means a lot to me. I am going to talk about endoscopic anterior approach to craniovertebral junction region. We all know that most of the CVJ anomalies are being managed now by the posterior approach, which is quite effective. The treatment by anterior approach can also address the basic pathology with additional advantage to access the anterior compression if by chance the pathology is not reduced, although most of them can be reduced perioperatively. In the anterior approach, there are mainly three approaches: transoral, transnasal, transcervical. In first two, transoral and transnasal, there is some risk of infection, but in transcervical, you go through the uninfected area. So this is quite useful. I'll be dealing with mainly two approaches, transcervical and transoral, in short, because the time is limited. Some facts about the CVJ: that irreducible AAD needs to be re-evaluated, as the anomaly that looks fixed and irreducible on dynamic image can be surgically reduced in majority of the cases. This is absolutely correct. And this was given by Professor Atul Goyal mainly, and many other surgeons. But certain percentage do not reduce satisfactorily. It means less than 50% reduction is there using only posterior approach. So a small number obviously require anterior approach also. And this percentage varies from 8% to 30% in various large series. So I'll be talking first on transcervical approach using endoscope. Uh, Transcervical approach is especially useful when there is incomplete reduction using posterior approach, or there are cases which are difficult to reduce. So initially, if you find something like tissue in between C1 anterior arch or odontoid process, fused C1 C2 joint, contracted tissue anterior to the C1 C2, malunion with fibrosis or callus, injury to the facet joint, which does not allow facet manipulation. There is less than 50% reduction or no movement on joint manipulation. There may be oblique C1, C2 joint, which does not permit very effective dissection, and the severe anterior posterior or cranial dislocation. So these cases are difficult to reduce. And in such cases, you can try uh, the transcervical approach in selected patients. I think this one, okay. So these are some of the cases in which there is a fused joint which does not allow movement, or there is a callus in between the odontoid process or the body and the C1 arch, or very severe basilar invasion may not be effectively reduced by joint manipulation. So the advantage of transcervical approaches are because both decompression and fusion can be done. It avoids contaminated corridor. There is a longer screw purchase, bicortical and longer screw purchase is possible, because even if you go posteriorly, lateral to the lateral mass, posterior to the lateral mass, there is no harm done. So you can get a bicortical purchase, which is the strongest purchase. There is less bleeding or no bleeding at all, minimum tissue dissection compared to posterior approach. The posterior tension band, which is very important, is preserved. There is a less risk to the vertebral artery, and the patient position is also better supine position compared to prone in the posterior approach. But there are limitations. It is indicated both in mobile and fixed AED. The contraindication when there is a large mandible which obstruct the access to this region, and if the mandible angle is lying below C2, C3 disc space, then the corridor becomes very acute and it is difficult to operate. If there is associated posterior compression like in cherry malformation, or if the facet joints are involved, which does not allow facet manipulation. In one of our case, you see the angle of mandible was at C4 level. So this is a contraindication for transcervical approach. The workup is same. You get X-rays, inflection, extension, and neutral position, open mouth, CT scan with angio to find out the facet joint anatomy in detail, especially the lateral mass and its dimensions, and the angio to find out, especially to rule out high riding vertebral artery, and even ICA sometime comes anterior to the C1, C2 facet joint. So all these things one should know beforehand and try and avoid complications. MRI is useful to find out soft tissue and the extent of neural compression. We all know that movement, inflection, extension, and even the reduction should be tried under general anesthesia. The anatomy of facet joint is very important, which tells us beforehand that which patients are likely to be easily reduced. And there are anatomies like fused joints, the vertical joints, or something in between C1 anterior arch and the odontoid process coming. Those are difficult to treat. One should carefully look at the ICA. It may be in front of C1, C2 and on the lateral mass, which may be easily injured during surgery. The vertebral artery also, the relation to the lateral mass of C2 should be visualized beforehand to avoid injury, and also to plan the screw in the lateral mass. So this was one of our cases where the left side the vertebral artery was just in front of C2 and in front of lateral mass, where you need to be very careful. You can mobilize it laterally, and there are variations in the vertebral artery, and sometimes the branches may be just in front of the facet joint, and you can injure these branches. So one has to be careful regarding the surgical procedure. The neck should be kept in extension position because it allows the angle of mandible to be pushed up. So rather than in flexion, the angle goes below, but in extension the angle of mandible can be pushed up, and this can be further helped by one is the extension of the neck, another is that one can close the mouth by doing the nasal intubation. So if you go for nasal intubation, you can purchase about more than 2 centimeter space, which is quite significant. and you can apply skull traction if required, if the trajectory is oblique, and short tubular retractor if you use. This can be pushed under the angle of mandible, and that obstruction can be avoided. Uh, the incision is below the angle of mandible. One can go for awake intubation, especially when there is a mobile AED, where during intubation, there may be a chance of injury to the cord, which should be avoided. The head can be slightly turned during the exposure to the opposite side. Once the exposure is achieved, then it should be kept in neutral position. The incision is about 1 centimeter below the angle of mandible, below the mandible, to avoid a marginal mandibular nerve. And the submandibular gland is mobilized up. The branches of facial vein and artery is also mobilized, and one should try to spare the marginal mandibular nerve, which usually does not go beyond 1 centimeter of the lower end of the mandible. Therefore, the incision has to be below 1 centimeter. The other important structures are posterior digastric belly, which should be released by detaching the fibrous loop from the hyoid bone. The other structure which is important and comes in the field is the hypoglossal nerve. So once you detach the posterior belly of digastric and mobilize it up, you will find the hypoglossal nerve, which should be carefully mobilized and pushed up. This is usually about 1 to 3 centimeter superior to the bifurcation of common carotid artery. Okay. So hypoglossal nerve is around 1 to 3 centimeter above the origin of common carotid. The prevertebral fascia is cut and dissected, and after that one can use either the EasyGo or Destendo or any other endoscopic site, and then the further dissection. Up to now, the dissection is under the microscope or open naked eye, but after this, all dissections should be under the endoscopic control. The gauze pieces are kept cranially caudally to the right and left so that the soft tissue does not protrude inside the tubular retractor. The medial end of the longus colli muscle, the articular capsule of the atlantoaxial joint is cauterized. The anterior constricting tissue, which are in front of C1 and C2, are also cauterized using monopolar insulated monopolar cautery. Now, very important thing is, although you can take help of C-arm, but under endoscopic control, you should identify the structures before going and doing any procedure. So identify the attachment of longus colli muscle onto this C1 anterior arch, which should be detached. So the attachment at the C1 anterior arch should be detached. You should identify the uppermost first disc, which is C2, C3 disc, and mark the midline there. Also, laterally, one should go and dissect both the facet joints, C1, C2 facet joint. So this is what should be identified before doing any procedure. So once you identify all these structures, then put a osteotome inside the facet joint, C1, C2 facet joint, and using the lever arm action under fluoroscopy, one should try to reduce the dislocation. And most of the time, the dislocation is reduced. So if the dislocation is reduced, then one need not to do anything except putting in graft there in the joint space after preparation of joint space, and then put C1, C2 screw or transarticular screw. I use C1, C2 lateral mass screw, and that's it. If there is no satisfactory reduction, the advantage of the anterior approach is that the compressing odontoid process or part of the C2 body can be excised in the same approach. So if it does not reduce, then I do the odontoidectomy and the medial corpectomy. One should be careful about the position of the carotid artery, which is usually in some cases, it is in relation to the lateral mass of C1. And the other structure is hypoglossal nerve. So in majority of these cases, even this hypoglossal nerve also comes in relation to the lateral half of the lateral mass of C1, which should be mobilized very carefully. So don't use monopolar cautery just inadvertently. You gradually push this, mobilize it, and then you can. So in the middle, one can use monopolar cautery, but laterally one should dissect carefully. Otherwise, you can injure the ICA, not the vertebral artery, ICA, and the hypoglossal nerve. At C2 lateral mask, there is a safe zone. So the safe zone is the superior part and the medial part of the lateral. So this is the lateral mass of C2. The superior and medial portion of C2 is the safe zone. So this is where you should put in screw. And at C2, because in the lateral portion of lateral mass, one can have invasion of the vertebral artery. The various types of high riding vertebral arteries are there. So, but in most cases, the medial and superior portion are spared. You can have lateral portion, you can have the inferior portion also may contain the vertebral artery, but the superior and medial is very rare unless you have a type 4 high riding vertebral artery. So the safe point of screw placement are at C2 lateral mass, medial, medial and superior, and at C1 it is the medial portion, but you can use it the lower also or upper one. But if you put in a screw in the upper one and goes posteriorly towards the this thing, then there may be possibility of injury to vertebral artery sometime posteriorly when the screw comes out through the lateral mass. So the inferior portion of medial and inferior portion of the lateral mass at C1 and this. So these are two safe screw entry points, and your screw should be directed slightly 5 to 10 degree laterally. All bone above the Walken hemline should be removed. So not only the odontoid process, but part of the vertebral body medial portion should be removed to allow good decompression. This is a short video of where the part of the C1 anterior arch was spared, incision below the angle of mandible, the mobilization of submandibular gland towards upper side, dissection of fascia, then mobilization and detachment of posterior belly of digastric from higher bone. This is the hypoglossal nerve, which should be mobilized very carefully and pushed up. Then prevertebral fascia is dissected, cut, and then the gauze pieces are inserted medially, laterally, superiorly, and inferiorly. This prevents the soft tissue coming in your view. And after that, the tubular retractor has been has been positioned using serial dilators, and then finally, and after that, all work is done under the endoscopy. So, longus colli muscle and anterior soft tissue removed. This is the facet joint on the left side. The soft tissue in front of lateral mask of C1 and C2 removed on either side. And then one should try to reduce. If it is not reducing, which was there in this case, so therefore we did the partial removal of C1 anterior arch and the odontoidectomy along with the part of the vertebral body removal until you find a good dural pulsation. So extent of decompression, the whole odontoid process need to be removed as is being done here, and how much of the C2, anything which is medial to the medial end of the facet joint. So a line, straight line connecting the medial portion of the facet joint, that portion should be removed so that there is adequate decompression. And in the end, you will find that there will be good dural pulsation. I remove the cruciate ligament if I don't see good pulsations. But if there are good pulsations, cord pulsation, then that is not required. This is the big piece of the bone which has been positioned in the facet joint after the preparation. The first screw is put in the lateral mask of C2, and then in the lateral mask of C1. On right side, this is bone being put in the joint space, and then the same thing is done on the opposite side. First is screw on C2 lateral mass, and then on C1, all under endoscopic visualization. So both plates in place with along with the autologous bone graft and good decompression. This is one of the child in which good placement of the screw. Another case with decompression and plate and a screw in position. Another case. So, but there may be complications like in one case when we went the screw position, it went in the posterior fossa. If there is too much of cranial angulation at C1, then this is possible. Fortunately, there was no dural injury, so no CSF leak, and nothing was required. If you angulate your screw in towards medially, you can go in the canal, which did not happen in any of our case, but these are possibility. There may be ICA injury, there may be redislocation, there may be infection, vertebral artery injury at C1 lateral mask or posteriorly when you use longer screw, because I use bicortical purchase and usually using 18 millimeter screws of 3.5 millimeter diameter is good enough. That provides bilateral bicortical purchase. Post-operatively, you should get X-rays to find out that there is good C1, C2 alignment, and fusion can be assessed later on. So to summarize, endoscopic transcervical approach is very effective and safe option in selected patient. It has advantage that both decompression and fusion can be done. Avoid contaminated corridor. There's a long screw purchase. Bicortical purchase is possible. There is no harm even if your screws goes beyond the lateral mass posteriorly. There is less bleeding. The posterior tension band is preserved. There is less risk of vertebral artery injury and better patient positioning. but there are limitations which I have already discussed. So briefly about the transoral approach. If I overshoot time, please let me know, because the topic is a little, but I think in 5 minutes time I'll.
No. Carry on. Okay.
Sir. So just to summarize, what are the various approaches? There may be transnasal approach for craniovertebral junction. This is the craniovertebral junction, lower end of clivus, C1, C2 region. So it can be approached using transnasal approach, endoscopic. So especially if the lesion is at craniovertebral junction and also going above the lower third of the clivus, so reaching the upper portion, then this approach may be preferred. Otherwise, for simple craniovertebral junction, this is also oblique approach. The most direct approach is transoral, which is almost at 90°, which should be there in any surgical technique. Transcervical is also oblique, and especially the angle of mandible comes in your view. But this is preferred when the lesion is there only at craniovertebral junction and also coming lower down at C3 or below. So in those cases, it may be preferred. For simple craniovertebral junction, transoral is most direct, but it is through the contaminated corridor. So this is a summary of anterior approach. The transoral approach can be used in fixed AAD, also can be used in mobile, but we avoid because of the contaminated corridor. The contraindications are same when the compression is also from the posterior side, like in ACM, or the facet joint is involved by the disease or trauma, then we don't prefer. Or if the lesion is extending above the hard palate, means in the middle of the clivus, the lesion is going up, then the transnasal approach is better. Or if the lesion is going below the C2 lower margin, then transcervical approach is better. If there is an intradural component, or if there is a lateral extension beyond the lateral margin of facet joint, then this should not be tried. So these are the extent of exposure. The inferior exposure is from the upper teeth to the retracted tongue, and usually it is up to the lower margin of C2. The superior exposure is from the lower teeth to the hard palate, and up to usually it is up to the middle of the clivus. So this much lesion can be approached by transoral approach. It is supine position, neck slightly extended, cervical traction is optional, endotracheal tube is placed on the left side of the mouth. The operative technique is same as we do microsurgery transoral approach. The neck extension as shown here, we use a long telescope so that the instrument manipulation is easy. Uvula and the soft palate is retracted up in the nasal cavity by infant feeding tube as shown here. I'll show the video. The posterior wall of the pharynx, oropharynx, is infiltrated with adrenaline and xylocaine. And very important is that you should pack the cavity with gauze piece so that the blood does not go by the side of the tube, either in the abdomen or in the respiratory passage. So packing. So the instrument, then telescope holder is used, and the instruments are passed by the side of the endoscope, and rest of the surgery is done as you do in the microscopic surgery. Exposure is excellent from lower clivus to the anterior arch or dentoid process and C2 without any problem, without splitting the soft palate. and laterally one should reach up to the C1, C2 facet joint. The medial half of the lateral facet joint should be exposed at least. The lateral half one can leave, but the whole of the C2 lateral mass should be exposed. The rest of the surgery is same. If there is a reduction, using the leverage, putting in osteotome in the facet joint, if it reduces, then you just fuse it. Otherwise, you need to do odontoidectomy also and removal of C2, part of the C2 vertebral body. This is a short video of transoral approach and the fusion in the same sitting. This was so-called fixed AAD. The patient positioning, Dingman retractor in place, the uvula and the soft palate being retracted using an infant feeding tube in the nasal cavity. Then infiltration of xylocaine and adrenaline in the posterior pharynx, incision in the posterior pharynx. One should stay in the midline. This is cranial, this side, cranial caudal, pharyngeal retractor applied, insulated monopolar cautery is used to remove the medial portion of the longus colli and the soft content. Now the osteotome is being used in both the facet joint and try to, reduce. If it does not reduce, then the removal of anti-arch of the atlas odontoid process and part of the C2 vertebral body is done, as is shown here. Axial drilling, and only the small Kerrison should be used only when there's very small part of the bone is left. I have already told that the lateral extent, anything superior to the lateral facet is odontoid process. So whole of the odontoid process should be removed, not incomplete, which has happened in 1 or 2 of our initial cases. And anything medial to the medial margin of the facet joint should be removed, even below the facet joint. That means the vertebral body, significant portion of the vertebral body of C2 need to be removed. So before surgery, one should determine how far one can see that a good cord pulsation, preparation of both the facet joints, up to the posterior margin of the facet joint. One can see the big piece of the bone is kept inside. The rest of the procedure is same. First screw in the C2 lateral mask, and then in C1 lateral mask. But the final tightening of is reverse. The C1 is tightened first, the C2 in the end. And after that, when obliteration of the dead space, one should prevent infection, and then the pharynx is repaired in a single layer or double layer under endoscopic control using interrupted suture. One suture can be used as a retractor. So when I apply, stitch is applied, then I keep that stitch intact so that it helps in my retraction. There is no continuous suture applied, but interrupted sutures. The post-op CT scan shows good screw purchase and the plate in position. So the advantage of transoral approach is that this is most direct, effective, and safe. palatal splitting or prolonged retraction is not required. One can be done when oral opening is as small as maybe even 1 centimeter. So even in 1 centimeter endoscope, with endoscope one can work. Surgery, whereas in microscopy you need at least 2.5 centimeter or 3 centimeter opening. So it's even if the patient has a small mouth opening, it can be done. It can be done in any neck position, whether flexion or extension, and it provides excellent exposure from lower clivus to C2, C3 disc space. But there are limitations. You are going through the contaminated corridor, and we have come across one infection out of around 75 cases we have done so far. There may be difficulty in closing dura, but now using the glue and this the dural substitute, this is not a problem if the injury is there. And there may be difficulty in early oral feeding, which may be slight advantage in transnasal approach. The exposure in endoscopic approach is far better of craniovertebral junction. Endoscope has more working area compared to microscopic surgery. On clivus also, there is significantly better exposure in endoscopy, and we found that this transoral approach is quite effective and safe in select patients. The risk of infection is there, but it is acceptable. There may be redislocation. So to conclude, endoscopic transoral odontidectomy and anti-fixation is a direct, minimally invasive technique which is safe and effective. The angle is scope improves the surgical exposure up to from clivus to lower margin of C2. Partial palatal splitting is not required even in severe basilar invasion. Mouth opening as small as 1 centimeter is enough to do decompression and fusion. Thank you very much. For detail, I think you can refer to our book with Professor Sharma sir we have written, and Dr. Jitin Bajaj. I think it is difficult. I don't have too much of experience of transnasal approach for CVJ, and I don't feel that it is necessary because most of the C1, when craniovertebral junction region can be approached directly either by transoral or transcervical. But if the lesion is extending above the middle of the clivus and in the craniovertebral junction, then you can use transnasal approach. And one can combine transnasal and transoral approach also, because you can put in endoscope in the oral cavity and the instrument through the nasal cavity, or vice versa. Thank you very much. I think I need not to explain the advantages and limitations of endoscopic versus endonasal or transoral. So thank you very much.
Thank you. Thank you, Professor Yadav, for the extensive description, which was clear and candid to all of us. May I now request the panelists to sort of give their opinion. Professor Daljit Singh.
Yeah, Dr. Yadav, very nice presentation as expected from you. Speaks a lot of experience in this field. And I still remember having visited you long ago when you had organized your first endoscopic meeting, and I was invited to do one surgery on endoscopic cervical. And I was amazed to see the number of patients lying of hydrocephalus lying in the ward. So since then, you have progressed quite well, significantly, and I'm really marveled you for those accomplishments. Regarding the presentation, transcervical as well as the transoral, I am not sure whether you switched on during your dissection from endoscope to microscope while you were drilling the odontoid. I thought part of it was.
Sir, I mean, I was doing microscopic surgery before, and then I started the endoscope. In transcervical, initially up to the exposure of C1, C2 region, it is under the microscope. So right from the beginning, it is not endoscopy. Otherwise, one can use VTOM. VTOM is just a microscope. So initial dissection in transcervical is microscopic. But once we come to the craniovertebral junction, the whole dissection is under the endoscope. In transoral surgery, right from the beginning, the whole thing is endoscopic surgery. Sir.
So Suri, any comments, please?
No, sir, it is excellent. No questions. Perfect.
No questions. Thank you. Thank you, Dr. Karmakar.
Yes, sir. I would thank Dr. Yadav for highlighting this wonderful exposition on the surgeries. We've actually published a certain technique, which is somewhat a modification of what Dr. Yadav has very finely described. Is a transnasal and a transoral, as he was talking about. When you approach the CV junction, the limiting factor for any endoscopic procedure is the hard palate. So we've actually used a hard palate line to determine the extent of the lesion above or below that line. The hard palate line is simply a line drawn from the hard palate back to the CVJ. And if your lesion is extending above that, then you can probably do a complete transnasal. If it is up and below, then you do a combined, as Dr. Yadav has pointed out. And similar factors to reduce or to move the soft palate away. You can instrument with through the transoral corridor and put your scope through the transnasal. So it actually gives you an increased angle of attack. If you see the approach to the lesion, it is much wider when you have both natural corridors available to you. And also reconstruction is an issue sometimes. So flaps have been described, including the pharyngeal flap instead of a vertical incision. So these are further modifications, just some additional technical details to what Dr. Yadav has nicely mentioned in his talk. Thank you.
Professor Sarat Chandra has got extensive experience in CV junction. Would you like to comment something, Sarat? You have to unmute yourself.
Thank you, sir. I think the talk by Professor Yadav was excellent. My only contention is that you can approach CV junction is a multifaceted pathology. You can approach it from various directions. But the most important thing is for the surgeon to become comfortable with whatever procedure he or she is doing and produce the least amount of morbidity and mortality. So I think all procedures are great. And it is over a period of time, these are innovations which come up. I really commend Professor Yadav for his work. I think they add up to the continuum of the entire armamentarium which contribute towards management of CV junction.
Thank you. My suggestion was, or my comments were, even if you split the palate, you were emphatic repeatedly of splitting the palate. I have split the palate n number of times and it heals very well in most of the situations. Probably that would still give you a further angle up instead of trying to going through the nose and the oral cavity combined. Sometimes you can just do this through the single cavity. So that was my suggestion. Splitting the palate for me is something terrifying or anything like that. And healing is very good for palate if you do it properly. Right. If that's okay with the permission of the chair, I now have the pleasure to introduce the next speaker, who is an eminent person again. And it is my pleasure to introduce Professor P. Sarat Chandra, who is Professor of Neurosurgery and Head of Unit 1 of All India Institute of Medical Sciences, New Delhi. He's also the team leader on the Center of Excellence for Difficult to Treat Epilepsy. So you see, it's a very interesting and demanding topic where he has to deal every day. He is a fellow of Academy of Sciences of India. He is fellow UCLA Los Angeles. He's a plenary fellow Wake Forest University, North Carolina. He's the chief editor of Neurology India He is faculty 1000 International League Against Epilepsy. He is the president-elect of the Indian Epilepsy Society, past president of Asian Epilepsy Surgery Society. He is the president of the Skull-Based Society of India, past secretary of CVJ Society. He has got 392 publications in index journals, and these are not simple journals. These are in New England Journal of Medicine, in Nature, in Genomics, in Epilepsy. So you can see his diverse and intense sort of work, which tells about his expertise. He has got 3 national awards. He has got quite a huge number of grants for research work regularly, which he conducts. And as a teacher, he is also, I'm quoting from his students. He is considered as one of the very good teachers in his institute. And he has devised many new surgical techniques, and they are really unique in the sense that endoscopic endoscopy, CV junction procedures, and so on. So, and as a human being, as a knowledgeable person, he is unmatched. Can I now request Dr. Sarat Chandra to give his talk, please?
Sarat is also a treasurer of this society, the Neuroendoscopy Society of India.
Yes, definitely.
Thank you very much, sir, for that very kind introduction, and also opportunity for me to be able to give this talk here. And I have been associated with endoscopy, I think, since the year 1999 at AIMS, when I went for training with at Greifswald with Professor Gab. And since then, I have been trying to see how endoscope can be combined with various other surgeries, or how it could be expanded into new areas. So nothing to disclose. Now, I thought I can divide the topics into 3 parts, mostly based on my own experience. The first part is obviously how we can modify the old techniques.
So that your screen is not coming to us. It's coming in miniature form.
Why is that, sir?
We did see the screen initially.
Now
We can see everything in miniature box.
Why should it be like that, sir? I don't know. I'll stop share and then start sharing again.
Please do. Yeah, it's there now.
Is it okay now, sir?
Yeah, that's good.
Okay. So I thought I should divide the talk into basically 3 parts. One is modification of the established techniques. I won't say old techniques, established techniques, on how one could modify using the existing instrumentation to take it forward. And second is the ability to create new instruments for making the established technique more easier or more efficacious or more safer, and also creating new techniques. So each one of them, and I'm proceeding only as per my own experience. So I'm not talking anything from the literature or anybody from other people's experience. So first is obviously for intraventricular tumors. I've been dealing with these tumors for the past 20 years. And I was the first to start doing endoscope for colloid cysts at AIMS. But over a period of time, understood that, excision of colloid cysts is not, endoscopically is not the same as any other thing. You do require a second port. And earlier when we had the GABS instrument or the endoscope instruments, one had to struggle with only one instrument to take it out. And then of course, I expanded to various other large pathologies like transcortical or interhemispheric approaches for large intraventricular tumors. I did try for this transparent sheath also, which is available commercially. So even though it looks quite attractive, but in actual practice, I didn't find it so useful. So I started using freehand endoscopy for intraventricular tumors. Now colloid cyst, we published this long time ago, and I have close to 100 experience of 100 patients. And here we have devised 2 main techniques. One is using a second port along the main port. Another is using a 50cc syringe, which is connected through a 3-way, so that we can allow powered evacuation of the colloid material. And this is using a 50cc syringe. So I've got a short video where I will show you the brief techniques for colloid cyst as well as for the other tumors. So this is a short video for colloid cyst. So that's the traditional view of endoscope. So cauterizing the choroid plexus. So opening up the colloid cyst using scissors. And now here I insert a thin syringe now which is attached, as you can see in the PIP, to a three-way which is open to a 50cc syringe, which is aspirated by my assistant, so that we can use a very good powered suction right from the cavity of the colloid cyst. So we are able to aspirate the colloid material, because this is many times this is very thick, and if it gets into the ventricle can cause hydrocephalus, and it's also very slimy. So once the entire colloid material is removed, the whole cyst starts flapping within the CSF. This is a pure intraventricular procedure. And that is where I bring in the second port and use the scissor to cut off the pedicle and excise the colloid cyst. Over years, I found that it is not necessary for us to excise the complete cyst, because even if some remnants are left, I've never seen this cyst growing back. So that is excision of the colloid material, colloid cyst completely, and one can see the mammillary bodies. So doing a septum pellucidal perforation. Now for excising the large tumors, we have devised the technique of either going interhemispheric or transcortical using a robotic system. And this is the same opening which I used for doing an endoscopic hemispherotomy or a corpus callosotomy. So this is a case of a large cavernoma. Where we are approaching it interhemispheric, exposing the corpus callosum between the two ACS. And this is using just a endoscope which is attached to a robotic holder, so that we can have. And now starting dissection of the cavernoma from all around, and then removing it completely. And you can see this is an excellent approach. There is absolutely no aberrations. Now we went in for more larger tumors later on. So this is a recurrent neurocytoma which was only partially excised elsewhere. So again we went through interhemispheric route. Open the corpus callosum. Dissecting it from all around. And this is a post-op. This is an example of a large optochiasmatic glioma in a 4-year-old boy. So in this, because it was going cranially upwards, we again used an interhemispheric approach, because the diencephalic floor was already thinned out and ruptured. And one can see the tumor as soon as one goes from the interhemispheric route and enters the tumor directly. And here I am running it at 2x speed. So since the endoscope is attached to a very nice robotic system, one can use bimanual approach. go down right till the floor of the middle of the anterior cranial fossa. So in hemispherotomies, we actually go down to the floor. So you go from the top and go down. So we get used to that concept. So this is for a transcortical approach where we use small flaps. It's a 24-year-old male presenting with headache and vomiting, having this large tumor with loculated horn. Now here we did try to put in this transparent sheath. And this was an old video, but obviously you can see that it's not so much of an advantage. In fact, the thickness of the sheet itself impedes your vision. So in this case, even though I was able to excise it, but later on I stopped using it. You can see that the tumor is very vascular and one has to be patient while working through this narrow corridor. And once we debulk the tumor and dissect it from all the sides, the tumor starts becoming less and less vascular. So that's the interface between the ventricle and the parenchyma. So that's the end of the surgery. So this is a large intraventricular meningioma, which again we used purely through an endoscopic assistance of 3 into 3 centimeters opening using the transcortical route. So I prefer using the wet gauzes, which are much more better than using cottons, because the cottons, once they get soaked up with blood, are very difficult to use along with suction because they don't suck out. Now you can see the tumor is being exposed all around. Use a Q-SAT to debulk it. It's quite a firmish tumor. So that's the end of the surgery. Little bit of residual tumor which has also been completely excised. And this was a meningioma arising from the choroid plexus. So using the same instruments, we were able to expand it for larger pathologies by having the sheer experience with endoscope. And these are the cases where I have operated various types of pathologies. Now, I've been always fascinated by the opportunity to use robotic guidance for pituitary. So obviously the advantage is that it provides a very stable holder. There is a very good feedback, doubles as a neuro navigation. Obviously it's very expensive, but once you buy it, you think, can you use it for other indications as well? But the disadvantages could be that there is no active movement. Sometimes the arm can freeze. There are no fast movements possible. So we combined it for pediatric cases. We combined it using the electromagnetic based navigation, which is very useful for children, especially when you're doing large cranios. And this is a robotic system what we have, the ROSA, which we primarily use for epilepsy. And there have been about 25 cases where I used it for pituitary tumors till we evolved further. And I will show you what we do currently. But this was a good system to use it initially. So you can see, if you want, you can latch the endoscope system to the robotic system. It forms a very nice stable holder. And then of course we approach it through the transseptal route. I do all my pituitaries through the transseptal route. Now, obviously the robotic system was not very convenient. So over a period of time, I started thinking, is there anything better we can do? And that's where I came up with this idea of trying to create a new retractor system for endoscopic pituitary. And if you look at it, pituitary and some craniopharyngioma forms the bread and butter for most of the endoscopic routes. And whenever we buy endoscopy, we have a bunch of these instruments, which somehow the younger surgeons feel compelled to buy, but most often you don't require it. And we all do the bimanual technique, which I never liked it because I don't like destroying both the mucosas on both the sides. And the question is, are we justified in destroying this pristine surface when we go through the transnasal route? And we cannot underestimate the extent of mucosal damage which can happen. So this was a recurrent pituitary operated elsewhere. When I put the endoscope, you can see that the whole cavity had become completely atrophic. Patient had developing atrophic rhinitis. And that's where we started working. We had our own research center, and it had this very nice program for devising instruments. So I sat with our own scientists and started designing.
This is the pituitary product that we are designing. You can see the locks inside. That means.
So we worked on various systems. So we worked on the special alloy.
The pituitary product, which is this now.
So we even tried
You can press
using
this and you can insert.
this kind of system where we have a rod
As you open, it has a
which
third
goes
side which it is
and
covered
locks the system on
this
both the
side.
sides. And finally, after a lot of trials, we came across the final system.
Okay. So we.
And this has been patented, and because it provides a very easy track, we thought we could call it as easy track, and it comes in 3 sizes. So it's dynamic, it's flexible, it minimizes the use of standard endoscope instruments, maximizes space, easy retraction. It's made of special alloy. It's just 0.3 millimeters thickness. It's coated with a non-stick Teflon. It's got fibrin coating on the surface so that it reduces the bleeding wherever it touches. And this is just a short video to show how this is used. So all my pituitaries, I do transseptal submucosal approach, which I find an excellent route. I never go through the transnasal route. So we open up and create a tunnel submucosally right up to the keel of the vomer. So once the tunnel is created, then one can take the pituitary retractor easy track, push it down till the base of the vomer, and then remove the ring and the wire which dispatches the retractor. Now one passes the suction in between the 2 blades of the retractor. And as they expand slowly, they also have expansile properties that breaks the septum right at the junction of the vomer. And I'll show you how it breaks. So slowly you have to nudge, and then it breaks the septum right at the keel of the vomer. And then you have a fantastic unopposed view directly to the silla. And now you can continue dissecting the mucosa on both the sides until you have a very nice exposure of the keel of the vomer. And then you can go on either side laterally, and because it's flexible and malleable, you could go laterally or you can stay in the midline. It's not rigid like a hardy speculum. And over here, we are using a down cut to free the keel of the vomer, so that once we remove it in toto as one piece, there is plenty of space for it to be removed. And once we go, you can see the sella very nicely bulging, and that also I remove it as this single bone flap which can be pulled downwards. And now you have the nice unopposed view. You can open the dura and then continue your surgery. And because it's so thin and so flexible, it gives a huge range of motions, and it's very easy. Within 3-4 minutes, you're there in the sella. So this is a traditional surgery which is carried out. And once the surgery is over, you can repair it, and then you pull out the retractor, and then I oppose the mucosa to one side to the septum and just take a stitch and bring the septum to the midline. So there is no need for us to place any kind of nasal tampons. There's absolutely no need. And once we do this, you can see that the mucosa is absolutely pristine. So using this technique, there has been minimal damage to the nasal cavity. And this has currently been commercialized, approved as a patent from AIIMS, and hopefully should come out soon. And it should be also quite affordable. So I have done both cranios as well as pituitaries, and these are the few examples, pre-op and post-ops. That's above is a pre-op, this is a post-op. And the best part is, if you need a Haddard's flap, it's very easy. You just remove the retractor cut the superior part of the opened up mucosa or loosened mucosa and the inferior part, and you have a very nice Haddad flap which can be used. And while you're doing surgery, the entire flap is away from your view. So you have a very nice unopposed view while you're doing surgery. This is a large cranium which I did, which I had to stage it because it's not able to remove it completely. And then we operated for this giant where we used a special type of retractor because the nose was very large in this patient. And this is how it comes. It comes in nice boxes and hopefully it should be quite easily affordable. So out of the 1,000 plus pituitaries which I've operated, I've till now operated EasyTrack using 30 cases and I've been quite happy with it. It's dynamic, flexible, thin, 0.3 millimeters. There is an amazing space, no fogging, and it's easy for endoscope. And obviously, it's the first customized disposable endonasal retractor for performing endoscopic pituitaries. And we had a small inaugural sessions in one of the conferences in Jabalpur. So the advantages obviously is what I've already mentioned. And then I come to the last and final vertical for expanding horizons of endoscopy, which is to create new techniques. And here I have been personally associated with creating two new techniques, which is now accepted world over, which are endoscopic hemispherotomy, endoscopic corpus callosotomy, and commissurotomy. And my interest with hemispherotomy started way back in 2002, where I operated this child who was having 200 to 300 seizures. You can see the incisor is missing. He had come in status, had to be intubated. And once we did the surgery, he improved completely. And after 15 years, he comes back as a young man, which shows the impact you can produce in these patients. And we produced the first ever hemispherotomy series from India. I learned the technique of open craniotomy from UCLA, from Dr. Gary Mathen. This is when he visited Delhi with his wife. But I realized that even though it is a hemispherotomy, still it is maximally invasive. We need to create something which is minimally invasive because the ideal population in which these surgeries are done are children between 3 to 4 years of age. And these are the pathologies for which the hemispherotomies are usually done, which is post-infarct, Rasmussen's, hemimegalencephaly, hemispheric cortical dysplasias. And one has to understand that these are not heterogeneous group of pathologies. You could have an atrophic brain where the doing an hemispherotomy could be very easy or straightforward. And you could also have some pathologies where it is good outcome versus in hemimegalencephaly where the outcomes may not be very good. But by and large, hemispherotomy is a dramatic surgery which can change the patient's life if it is done properly. The only issue is being the large craniotomy and blood loss. So in 2002 to 2008, I did transcranial approaches. Then using navigation, I switched over to interhemispheric approach because we had intraop MRI. And from 2012-8 onwards, I started developing the endoscopic hemispherotomy. So initially when we developed this concept, it sounded as easy as trying to pass a camel through the eye of the needle. But over a period of time, this is what we settled for, a craniotomy of 3 into 4 centimeters in the anterior part of the skull. And because we have an anterior approach, we avoid all the major draining veins. And because of the endoscope, we will be able to reach even the posteriormost part of the target. And now this is the whole footprint of the target, because when we are going endoscopically from the front, we reduce the footprint by almost 50%. Unlike the traditional transcranial approach where we go from the top and the footprint is quite wide. So we were the first to describe the hybrid technique whereby we use the thick scope, which you don't take it up right up to the target, but keep it so that we can have a bird's eye view. And this is published in Journal of Neurosurgery. And this is how I attach it to a robotic system while doing surgery. And proper ergonomics is very, very important. And you can see that the robotic system provides complete comfort while doing the procedure. So when we developed the technique in 2014, we published a bunch of very nice papers, which made it acceptable all over the world. And many centers started doing this technique. And I did my first presentation in the reputable conference called as Epilepsy Surgical Technique Meetings, which is held once in a year. And this time when I presented in 2020, I presented a completely new bloodless technique for doing hemispherotomy, it's a bloodless technique for doing hemispherotomy, which will be out in the Journal of Neurosurgery in next month. Now, we started initially with atrophic pathologies like this. So we could easily go ahead and do an endoscopic disconnection. And then when we gained experience, we went on to do it for all non-atrophic pathologies. Like this is Rasmussen, you can see the disconnection very nicely done here post-operatively. And currently we do it for all pathologies, including non-atrophic pathologies. And you can see very nice disconnection of the endoscopic hemispherotomy, which has been done there by going through the interhemispheric route. And this is a patient which I operated in Malaysia, where you can see there is an hemimegalencephaly. It's the most complex pathology with aplasia of the frontal horn. And we went ahead and did this. There was just 40 cc of blood loss. And the child was having about 100 seizures, did completely well after the surgery. And then, of course, we had more papers and more acceptability. It went on to get accepted in textbooks of pediatric neurosurgery, pediatric epilepsy surgery, and also in operative techniques. And then, of course, we published this landmark paper in New England Journal of Medicine, where we showed that in a randomized controlled trial, surgery for children is 7 times more efficacious than medical therapy, which also included hemispherotomies. And this was one of the top 10 papers of NEGM for the year 2018, and currently has more than 250 citations. And then this is our latest publication, and I encourage all of you to go through this publication where we described the hybrid technique. And following a description, there have been various other papers from other centers where they have actively started doing this procedure. With the last fellow, Jitin, we also described the causes of failures. So we showed that there could be a temporal stem which could be left behind, and how to tackle the temporal stem. And by tackling the temporal stem, we were able to increase our efficacy from 80 to 90%. And again, we published this in JNS Pediatrics, which is again a very well cited paper. And we showed that even if the temporal stem is left behind, the repeat surgery is easy. It takes only 15 minutes and should be considered as a staged procedure, especially when we are tackling with complex pathologies like hemimegalencephaly. And the reason why temporal stem could be left behind is because when we do hemispheric disconnection, the temporal stem is round the corner. So we use a straight endoscope, and unless we have curved endoscope or we have the ability to curve the ball like Roberto Carlos, because it's around the curve, there is a tendency for the temporal stem to be left behind. And this is what made me start thinking of a new procedure, which I will show you as one slide in the last part of my talk. Now, when we approach from the interhemispheric route, the area which can be left behind. So if you see, when you go peninsular, the deepest area is the interhemispheric area. When we come from interhemispheric route, the deepest area is the temporal stem. So this is the most superficial area. So if you see, this patient was operated by a very dear colleague of mine during Ginde's oration in Mumbai, where I also had done an endoscopic procedure. But this was a very difficult case of hemimegalencephaly, and you can see there was a connection left here because it was from the peninsular area, peninsular route. And when the patient came, we did an endoscopic disconnection from the front, and we were able to disconnect it completely, and the child became completely seizure. And this is the incision through which we did it. In my presentation at the keynote lecture in AANS San Diego, I concluded that endoscopic hemispherotomy is safe, effective, minimally invasive. We do it for all pathologies. There has to be a definite learning curve. And when we address the temporal stem, and if we requires a repeat surgery, we can enhance the outcomes further to almost 90%, as a repeat surgery is simple. It's also come on Wikipedia. My net was not working, but the fact that endoscopic approach is now quoted in Wikipedia means I think there is a global acceptance for this procedure. I will end with a short video.
Sturge-Weber syndrome. The child preoperative.
So these are the 3 steps of the procedure.
So the hemisphere is retracted to one side. You can find here that there was a hole in the fox. Hence, both the hemispheres are opposed to each other. But as we go deeper with further dissection, now you can see the fox. I prefer the usual microsurgical instruments, and the endoscopic you see is a rigid 10 millimeter scope. The corpus callosum is now exposed from the genu till the level of splenium. Now, once the corpus callosum is exposed from the genu to the splenium, I prefer to start the corpus callosotomy from posterior to anterior, more as a matter of convenience, and also for the fact that splenial disconnection is a little bit more difficult. Now, unlike traditional corpus callosotomy, in this case, when we perform the corpus callosum, it is important to open into the affected ventricle. That's the choroid plexus. The dissection is proceeded more ventrally till one reaches the genu and then loops down till the level of the rostrum. And these are the two anterior cerebrals, the A2s, which are curving around the genu. The rostrum is now exposed using a blunt dissector up to the level of anterior commissure. So that marks the end of corpus callosotomy. Now we come to step 2, which is anterior and middle disconnection. The anterior disconnection is a transverse disconnection. It starts at the extraventricular region, at the junction of the genu and the A2s. It's very important to start it extraventricular so that one prevents damage to any of the deeper nucleus. So the dissection is proceeded inferiorly till one reaches to the posterior part of the anterior cranial fossa. The anterior, one can now see the olfactory tract. The anterior disconnection is now proceeded laterally in front of the head of the choroid nucleus till it reaches to the lateral part of the putamen. And from here, we start the middle disconnection, which starts at the extreme end of anterior disconnection and passes posteriorly in a parasagittal plane till the level of atrium. The middle disconnection would pass deeper in order to reach the temporal horn posteriorly and the MCA encased within the arachnoid plane more anteriorly. This generally is the most difficult part of the hemispherotomy, and it is useful to have neuronavigation at this stage in order to prevent swaying towards the midline. You can see now we are passed posteriorly, lateral to the thalamus, and we're going deeper till we hit the temporal horn. Now that is the hippocampus, and this is exposed posteriorly till the level of atrium. Now following this, it is very important to suck out the ventral amygdala and the anterior part of the head of hippocampus, because one has to understand that even though the temporal lobe is not connected to the midline, but the ventral amygdala is through the dorsal amygdala. Now we have completed the middle disconnection. The final part is a posterior disconnection, which is between the choroid plexus and the splenium of corpus callosum. And this effectively disconnects the temporal efferents, which consists of fornix and the tail of hippocampus. Starting anteriorly, which is the anterior disconnection, going backwards to the middle disconnection, which is in the sagittal plane, and then curving around for the posterior disconnection. Medially, one can see the extent of corpus callosotomy.
So that's the size of the incision is just 2 centimeters, 3 centimeters in long. And now in this ESTM in 2020, for the first time I presented a bloodless technique of doing hemispherotomy, which I called as robotic thermocognitive hemispherotomy, which is abbreviated as ROCH. Now ROCH incidentally stands for a small Arctic bird, which is common along the coasts. And since it's gentle on kids, it's most minimally invasive procedure, I think, in the whole planet. So we just use couple of sutures. There is no blood loss, and we produce using robotic guidance a thermocognitive disconnection. And we have done it in about 8 patients, and they are doing very well, including a 3-month-old child. And you can see very nicely how nicely there is a thermocognitive disconnection rather than endoscoping. And this is the future. This is what is going to happen. We are going to do bloodless techniques whereby we are going to produce bloodless disconnections using laser and thermocoagulation. So I think personally for me, it's been a journey of 20 years where I witnessed anatomical hemispherotomy with huge blood loss and morbidity, coming to a satisfaction of doing a technique which is now bloodless for doing this very complex surgery. And it's going to come up next week in Journal of Neurosurgery. And hopefully this should be on the cover page. So concluding, endoscopy or endoscopic assistance is just another seamless integration into the neurosurgical armamentarium for better and safer surgery. Endoscopic epilepsy surgery is just the tip of iceberg. But I think over a period of time, it's going to be replaced by laser or radio frequency disconnections. Better innovations will make endoscopy safer, better, and cost effective. Thank you very much again for this opportunity.
Thank you, Professor Sarat Chandra. That was really outstanding. And we are really proud of your achievements and your innovations. And this is really absolutely great. May I now request the panelists to give their comments, please. Professor Daljit Singh.
Yes, Sarat. As expected, it was a wonderful presentation showcasing your excellence in the field of endoscopy as well as particularly in epilepsy. We are all proud of you. Accomplishment is yours, but we all feel very happy to have such a good work coming out from this part of the globe. I still feel, I mean, you have been fortunate to have been equipped with all the equipments which is required to utilize. So, so what is your advice to the people who are, in the lesser mortal, do not have robotics, do not have things to, so how should they be doing, helping the peoples who would be benefited?
So robotic system, we have bought more for doing the stereoencephalography. That is what it has been created for. But it's so terribly expensive that in order to validate its purchase, we started using it for other approaches also, other surgicals also. But many times we have done using the usual endoscope holder. So because many times the robot has frozen or it could not work, and then we had to take the usual endoscope holder. And when I demonstrated this in Ginde's oration in Mumbai, I used a routine endoscope holder. So it can be done. But yes, there is a definite learning curve for this procedure because it's not like the usual endoscope. You need to really be aware of the entire anatomy. You should know where is the entire anatomy. It's like going around the entire brain. It takes about 80 minutes for me to do the surgery. So it's like going around the world in 80 days. I say going around the brain in 80 minutes. That's how I call it. And you practically see each and every structure. This is possibly the only surgery where you see each and every structure in the brain. So you have to be aware of the anatomy. For that, you do require a little bit of learning curve.
Thank you. Professor Ashish, Suri, any comments?
Oh, sir, we are in the same institute and he's the flag bearer. So you cannot really comment on your own colleague.
Right. But anyway.
Can I ask one question? Sarat, no, excellent job, actually, there is no doubt about it. My question is that there are two questions. One is about using the robot. When you use robot for this kind of surgery, you get to have the endoscope holder number one, okay, and the navigation, okay. So people who do not have an access to robot, do you suggest them to have, do the same kind of surgery using just the navigation techniques along with the available endoscope holders rather than going for this robot?
So my advice to people is that first you start doing a large interhemispheric microscopic approach. So do a large flap, open the hemisphere, get used to the anatomy all around, put an endoscope and try to learn about the anatomy. Second advice is start with atrophic cases like post-infarct with epilepsy. Those are the excellent cases where you can start off these cases. Don't reduce the flap till you are comfortable with the anatomy. The third is the advantage of robotic. What I found is that it's got a haptic feedback. So whenever the assistant releases the clutch or the brakes of the robot, the whole weight of the robot doesn't fall on your hand. So when you keep on doing surgery over a period of time, it's very comfortable for you to keep on moving all those micro movements. Whereas the traditional holders, the problem is moment the assistant releases it, the whole weight of the endoscope falls on you. So by the time it's okay for surgeries which last for 45 minutes, 40 minutes, 30 minutes, but after some time it becomes, kind of exhausting whenever the weight falls on your hand. But again, does it justify purchase of such an expensive system? So I don't say that you need to buy, you can do it very nicely with a very good endoscope holder. But the most important thing is to learn the anatomy and have a very nice smooth curve so that you can start with atrophic cases, start with interhumerus. So I started mine with peri-insular. Then I went to Delalande's transcortical, not interhemispheric, transcortical vertical. And then finally I switched over to interhemispheric microscopic. And then I went on to endoscopic.
Right.
Thank you. Thank you. Dr. Vikram Karmarkar, any comments?
Wonderful presentation. I was fortunate enough to witness the surgeries mentioned in the Ginde oration. But this is regarding a question regarding your other innovations for the easy track. Have you used it for extended skull-based procedures, like for a craniopharyngioma where you would have to drill the tuberculum cellae and things like that? And does that change your approach using the easy track device that you have created, sir?
So I have used it for one case of craniopharyngioma, where simply I had to move the easy track more posteriorly and then do the extensive drilling. And in the end, what I did is I removed the easy track and then I cut the superior part and the inferior part and used as an Haddad flap and then used it to repair the leak. But unfortunately, that is where the COVID came in. And now I'm really afraid to do any endoscopic approaches till the COVID completely disappears. Hopefully it should happen by middle of this year. Right. And then I will raise. Many surgeons I know they have started resuming endoscopic surgeries, but I am a bit apprehensive of starting to do endoscopic surgeries during this time.
Right. Thank you.
But it is a very convenient. It's going to be inexpensive. I can send you some samples if you want.
Sure.
If you want to do it, it's a very nice, convenient. Within 5 minutes, you're there on the keel of the wormer. It's a midline approach. You don't need a ENT surgeon. It's an approach which you very well understand. You can extend it to make it an extended approach. And the more you use it, you'll be comfortable. You're not touching the nasal cavity at all. So nasal cavity is completely pristine. And the technique which I'm using was described by Hirsch in 1940, the transseptal approach. He was using the Hardy speculum, but we are using endoscope, and it's a very nice approach. I really find it good.
Correct. Thank you. Thank you.
And I request the president to take over, please.
Thank you, Ashish. It is my great pleasure to introduce and invite Professor Alberto Feletti. Professor Feletti comes from Verona, the University of Verona Neurosurgical Department, where he has been trained and is presently working. He has got tremendous experience in the management of neurosurgical problems using the endoscopic methods, and particularly the new endoscopic method, particularly with the flexible endoscopy. And that is what he is going to talk to us about. He has got a tremendous, large number of publications, and he is always ready to really help us in the various workshops and webinars and seminars. So his education interest is very, very huge and great. And we thank him for accepting our invitation today to be here. Welcome, Professor Feletti. Please go ahead with your presentation. Thank you.
Thank you. Thank you very much. First of all, I want to thank the Neuroendoscopy Society of India, and in particular, Professor Sankhala, for inviting me. It is a real pleasure and honor to be here with such eminent and experts speakers. I really enjoyed and learned a lot today from the previous talks. I hope also my talk will be of some interest to you. The aim of my talk today is to give a panoramic view of the potentials of flexible endoscope, both for brain and spine surgery. I have nothing to disclose. Well, we know that for ventricular endoscopy, we can use either rigid or flexible scopes. I will give an overview of the procedures in the lateral third, fourth ventricle, and spinal cord. I will start with lateral and third ventricles. I will skip these procedures: septostomy, biopsy, fenestration of cystic craniopharyngiomas, ETVs, or fenestration of obstructed Monro foramina, and removal of colloid cysts. Why I will skip? I will skip these procedures because these kind of surgeries can be performed also using a rigid scope in a very nice way. We just saw Professor Chandra. He showed nicely removed colloid cyst in his presentation. So otherwise, I want to spend a few words about these procedures, but in this specific topic of the use of fluorescent sodium intravenous injection during these procedures. If you use a special filter for your endoscopic camera, you are able to see some areas of the ependyma surface which are lacking the blood-brain barrier. Of course, the choroid plexus is very nicely visible, but not only that, also some circumventricular organs like the median eminence, which is located at the level of the tuber cinereum. If you know where this organ is, you can actually try to tailor ETV in order to reduce damage to this organ. And it is interesting to see that you can apply the same technique also in the fourth ventricle. This is the area postrema of the fourth ventricle, which is also lacking the blood-brain barrier. And fluorescent sodium is a good tool also in those cases when you want to perform a biopsy. Some tumors are very evident inside the ventricles, but in some cases there is no exophytic part of the tumor. So in those cases, we found fluorescent sodium very useful to highlight the site for a proper biopsy. Besides biopsies, it's possible in some selected cases even to remove a tumor just using an endoscope, like we did in this case of obstructed cerebral aqueduct because of a tumor at the level of posterior third ventricle. We found the tumor to be very soft, and it was actually possible to aspirate the tumor and remove it. Sometimes it's possible also to fenestrate arachnoid cysts if they are facing the ventricular system, like this huge arachnoid cyst of the quadrigeminal cistern. I entered the third ventricle through, of course, a precoronal bar hole. This is the cystic wall facing the posterior third of the third ventricle. With coagulations, I created a first hole, which can be enlarged, of course, with a Fogarty balloon. And here I am inside this large cyst. You can see the cerebellum, the tentorium, the free border of the tentorium, the straight sinus, the ampulla of Galen, the internal cerebral veins. So you can also have a very nice view. And the postoperative course was very nice for this patient with resolution of symptoms. But let's move to a more deep part of the ventricular system. In the ancient era, Ancient Greeks thought that the world had a border, and the western border was located at the level of the Pillars of Hercules. It's the place we nowadays know as the Strait of Gibraltar. Ancient Greeks people thought that it was not possible to cross this border. Why? Because crossing this border would have led to nothing. Nothing could be expected at the other side, probably just danger and death. Sometimes I feel that for many years, the cerebral aqueduct has been like the Pillars of Hercules for neurosurgeons. The introduction of the rigid endoscope allowed us to inspect this area, but it was not possible to cross, of course, with a rigid scope, because only damage can be done crossing the cerebral aqueduct with a rigid scope to our patients. But nowadays, with flexible scopes, we can go beyond that border. Look at this case of membranous obstruction of the cerebral aqueduct. In such cases, when the obstruction is due to a membrane, so it's not like a true stenosis, but it's a membranous obstruction, it's possible to fenestrate this membrane and recover the patency of the CSF pathway. Here I am in the fourth ventricle of this patient. This patient went well with just the fenestration, no need for ETV in this case. This case shows the pictures of a patient with a posterior fossa arachnoid cyst, cisterna magna arachnoid cyst. No symptoms for this patient, but in the follow-up, the patient started complaining for symptoms of increased intracranial pressure, and actually the MRI showed an increase of this arachnoid cyst. So we performed an operation using a transaqueductal transmagen-D foramen fenestration of arachnoid cyst. And this is the video. Here I already entered the fourth ventricle. You can see the fourth ventricle is very narrow, of course, is very narrow in this case because of the presence of the cyst behind the cerebellum. I moved my endoscope very carefully between the brainstem and the cerebellum, all the way down to the Magen-D foramen. It was a very narrow space, but the flexible scope can nicely adapt to the irregular geometry of the system, of the ventricular system. This is the central medullary canal. This is the pica, and this is the wall of the cyst. I always look through the wall of the cyst, and I try to fenestrate when I see it's transparent, so I can see what's at the other side. Here you can see it's transparent. So I did a fenestration with monopolar coagulation. You can, of course, enlarge this fenestration with Fogarty balloon. And then I shrinked the wall of the cyst with coagulations. And this is the end of the procedure with a very open Magen-D foramen and picas visible. And retracting the scope, you can see the fourth ventricle got enlarged back to the normal size again. In this case, I also performed a third ventriculostomy just to be sure hydrocephalus will not occur again. In selected cases, it is possible to do also a Magen-D-plasty or Luschka-plasty. We published this kind of operation for the first time some years ago, and the same operation was also used by a Mexican group with a larger series of cases with success. If we consider the whole CSF pathway, probably the most interesting application of flexible endoscope is when dealing with intraventricular hemorrhage. Intraventricular hemorrhage is a very bad condition, irrespective of the cause of the hemorrhage. It carries a high mortality rate, up to 8% in some series. It has been shown that amounts of blood in the ventricles larger than 20 milliliters can be lethal for patients. So it's necessary to get rid of this blood as soon as possible. Usually these patients are treated with external ventricular drainage, which is a simple procedure, and it allows for a fast resolution of acute hydrocephalus in these patients. But we know that very often we must place two EVDs in these patients, and these EVDs frequently obstruct, and still we have to wait for a long time to see blood in the ventricles to be washed out. So the consequence is a longer hospital stay and an increased rate of complications, for example, infections. Fibrinolytic therapy can speed up the process, but still we need to wait days. And probably the rate of infections can be higher when doing this kind of procedure. But with a flexible scope, it's possible to aspirate intraventricular hemorrhage from all ventricles. As you can see from these pictures, these are the preoperative pictures of this patient. We can get to the fourth ventricle, not only the lateral and the third ventricle, and get rid of blood immediately. It has been shown that with this method, we can improve the outcome of the patients and decrease the mortality rate, and probably decrease also VP shunt dependency in these patients, as published by Basaldella and colleagues a few years ago. We use the operative channel of the flexible scope as a sucker. It is important to place a bar hole pre-coronal, but not too lateral in such cases, because if you place the bar hole too more lateral than 1.5 centimeters, the scope has not the same direction of the cerebral aqueduct. So it will be very difficult to enter the cerebral aqueduct in those cases. We cannulate the ventricle using a peel away, and we use a three-way tap to connect a syringe for aspiration and water for irrigation. And actually, irrigation and aspiration are the most important maneuvers in this kind of procedure. Irrigation is useful to unveil anatomical landmarks, and also to balance aspirated blood, especially from the fourth ventricle. And aspiration maneuvers are required to remove blood clots. These are different phases of the procedure. The first one is removing blood from the lateral ventricle, which is probably the most time-consuming part of the intervention, but also the less useful. The most useful parts are the removal of blood from the third and the fourth ventricle. This is a video showing a case of intraventricular hemorrhage. As I always say, initially this kind of surgery can be very frustrating because the only thing you can see is blood, is red on the screen. But you have to be positive in these cases and start aspirating and irrigating. Stop aspiration when the white ependyma appears to avoid damages to the ventricular walls. And then some landmarks start appearing, like the interface between the clot and the ventricular wall. And if you keep alternating aspirations and irrigations, you can find what is probably the first landmark in such patients, which is the choroid plexus here. This is a very important landmark because you can follow the choroid plexus all the way to the back part of the lateral ventricle to maximize aspiration of blood clots. This is the back part of the ventricle, but you can move the scope forward, always following the choroid plexus until the plexus leads you to the Monroe foramen, which is, of course, obstructed by blood clots. And you have to remove blood clots from the Monroe foramen, again, with aspirations, until the anterior part of the third ventricle is released. Here you can see the mammillary bodies. The vision is not good in these cases because the CSF is dirty because of blood. This is the infundibulum, the optic chiasm, the lamina terminalis here. And then you have to bend the tip of the scope all the way towards the back part of the third ventricle. And with the same maneuvers, aspiration and irrigation, you can remove the blood also from the posterior third of the third ventricle until you can see the additum of the cerebral aqueduct. Of course, obstructed by more clots, but further aspirations of these clots completely clear your vision of the additum, the posterior commissure, the habenular commissure. This is the pineal recess. And you can see also the roof of the third ventricle here with the internal cerebral veins. Then you can move the scope through the cerebral aqueduct. You can nicely see the anatomy of the cerebral aqueduct with the two constrictions and the ampulla, and remove the blood clots obstructing the lower cerebral aqueduct. Allows you to enter the fourth ventricle. When you are in the fourth ventricle, it is very important to balance the volumes of irrigation and aspirations because the flexible scope has the same diameter of the cerebral aqueduct, so the water cannot flow outside. This is the central canal, the ependymal central canal. Further aspirations unveil the picas here. This is the choroid plexus, and this is the left Luschka foramen. This is the inferior triangle of the fourth ventricle. Here you can set also the right Luschka foramen free, and then you can move to the Magendie foramen and aspirate blood also from the Magendie foramen. And you can recover the patency of the whole CSF pathway. This is the cisterna magna seen through the Magendie foramen. And then you can withdraw the endoscope. And as you can see, no damage is done on the cerebral aqueduct in these cases. The results are very nice, as you can see from these pictures, and this technique can be applied also in cases of intraventricular hemorrhage due to aneurysm rupture, like in this case of this patient with pericallosal artery which ruptured. He underwent coiling, and then immediately after endoscopy, and in less than 1 hour we could set all the ventricular system free of blood. Or this case of basilar artery aneurysm, which was coiled, and then the patient went directly to the endoscopy procedure. I think the improvement of the compression of the posterior fossa after endoscopy is very clear comparing the pictures of the CT scans. Similarly, you can use endoscopy also when you clip a ruptured aneurysm with intraventricular hemorrhage. In this case of left MCA aneurysm with intraventricular hemorrhage, I clipped this MCA aneurysm. This is the immediate postoperative CT scan, and I immediately went on with endoscopy, removing completely blood from the ventricles of these patients. What about the spinal cord? It is possible to use this technique, for example, in cases of empyema. In this patient, I performed a small laminotomy, and I entered the spinal canal with my endoscope. Similarly to the intraventricular hemorrhage cases, initially the vision is very impaired because of the pus. But with the same techniques, same maneuvers, irrigation and aspiration, you can patiently remove this purulent material from the spinal canal of this patient. And you can also see some landmarks like the perimedullary fat, which tell you that probably you properly decompressed the spinal cord. And you can, with the tip of the scope, even scratch the walls of the canal to completely remove this pus. In this patient, I used the endoscope to inspect the inside part of a syringe. This patient had a post-traumatic syringomyelia. This syringe was operated in another center a couple of times, just with a microsurgical approach to release some arachnoidal and fibrous attachments of the spinal cord. Colleagues opened the syringe, but the syringe recurred both times. So the patient was referred to me, and I did the same operation with microsurgical inspection and detachment of the adhesions, but I also navigated inside this syringe, and I opened some septa that were obstructing the syringe inside. As you noticed, I also again used sodium fluorescein to highlight eventual vessels that cannot be damaged. So before cutting, I always inspect the cavities with fluorescent sodium in order to minimize bleedings. So this is the inside of the syringe. I made sure that no obstructing septa were present, and I opened all these obstructions. And the patient went well. She improved her symptoms, and after 8 months, the syringe did not recur like before. In the previous operations, the syringe recurred 3 months after the operation. So take-home messages from my experience is that flexible endoscope can allow you to explore the whole CSF pathway. There are some tips and tricks. I think the most important are about aqueductoplasty, which can be safely performed only if a membranous obstruction is present. But if there is a real stenosis, aqueductal stenosis, my advice is to perform an ETV. And in the fourth ventricle, it is very important to balance irrigations and aspirations, because flexible scope can obstruct the outflow of fluids through the cerebral aqueduct. So if you don't balance aspirations and irrigations, you may have bradycardia, in this sense, the collaboration with anesthesiologists must be very, very tight. For IVH aspiration, I think this method can allow a quick restoration of CSF pathway and to decrease intracranial hypertension in these patients. It is a low invasive procedure which can reduce the frequency of EVD obstruction and replacements, and also reduce shunt dependency. And as you could see, this tool is very, very versatile, and you can use this scope also in the spinal canal. Thank you very much.
Thank you, Professor Feletti, for this excellent demonstration of your technique. I'm sure with the help of the flexible endoscopy, you must be doing a lot of work in tumor removal from the temporal horns and the area around it. Can you tell us, in case of IVS and the arachnoid cysts, can you introduce you through the retrograde way from the posterior fossa upward?
Yeah,
safely?
I did in some cases. About the case I showed with the cisterna magna arachnoid cyst, of course, my first thought was to approach the cyst from behind. But as I noticed that the cerebral aqueduct was patent and it was possible and safe to navigate through the cerebral aqueduct, I thought that going through this frontal route would give me two advantages. The first is to avoid opening posterior fossa, which has a higher risk of CSF fistula, and it is also more time consuming. Second advantage was the possibility, the eventual possibility to perform an ETV to reduce the risk of recurrent hydrocephalus in this patient. But in some cases, I approach the ventricles from the fourth ventricle, actually, upside, from down to up. And I do this, for example, when I perform microsurgery in posterior fossa in the prone position. I remember at least two cases of very bleedy tumors. After removal of those tumors of the fourth ventricle in the prone position, we were worried that blood could have entered the ventricular system and have passed through the cerebral aqueduct going to the third ventricle. So I explored the third ventricle from the fourth ventricle, and I found blood clots, and I removed blood clots by aspiration. So in such cases, those blood clots can, lead to acute hydrocephalus in the postoperative course. So I think it's also a good indication.
Absolutely, it is. Thank you very much. Daljit, any question to Professor Feletti?
Yeah, a very nice presentation. I really liked it. Do you practice removing of intraventricular hematoma in every cases of clipping or coiling? Is it a routine, or you do it only in selected cases?
Yeah, good question. I do only in those cases when an EVD is required. So if an EVD is required, then, it takes nothing for me to insert the flexible scope and aspirate blood before leaving the EVD. But in those cases when EVD is not required, I don't use. This is in general, not only for a ruptured aneurysm, intraventricular hemorrhage. So in general, for intraventricular hemorrhage, I do endoscopy only if EVD is required.
So do you combine rigid scope as well as flexible scope for the removal of intraventricular hematoma, or you only use flexible?
I combine rigid and flexible in some cases, but not for intraventricular hemorrhage, because it's more time consuming for me to change the instrument. Probably for people who are not used to flexible endoscopy, that would be a good way to start. because of course rigid endoscopes have a better quality of vision compared to flexible scope. Probably this will not be so true in the near future because a flexible scope with a chip on the tip has been already created. Unfortunately, we cannot use that nice tool in Europe because it was not certified yet, but I know in Japan and in other countries they are using. So with this tool, the vision is like microscopic vision, but it's possible to combine rigid and flexible if you need. Yes.
Thank you.
Yes, Sarat, please.
Excellent lecture, Dr. Felicity. My question to you is, with your experience of flexible scope, have you used it for some other indications like for carpal tunnel syndrome, where you could make a small incision and do a carpal tunnel release using flexible scope?
I'm sorry, I didn't get your question.
Yes, my question is that with your experience of using flexible scope, did you consider using it for other indications like for carpal tunnel surgery?
Oh, no, actually, no. I have never used for tunnel carpal. So I know there are people using endoscope for carpal tunnel syndrome, but probably most people are using rigid in those cases. If I had to use a scope for carpal tunnel syndrome, I would probably use rigid scope because the working channel is bigger, because the vision is more clear, and because you know, I use a flexible scope in the ventricles because of the irregular geometry of the ventricular system, and because I don't want, moving the rigid scope, I don't want to get damage to the brain parenchyma or to the fornix. But for carpal tunnel, I wouldn't be so worried about moving the scope in the wrist. So probably now the rigid scope would be the best for such kind of operation, at least until a better flexible scope with a nice view and larger operating channel will be available. Same is with for craniosynostosis. The rigid is always preferable than the flexible. Yeah. Yes. Is Dr. Suri with us? Ashish?
Yes. Unmute yourself.
Yeah, actually, I've had a good experience of flexible scopes, especially with insisted ventricles, and I have a paper in Journal of Neurosurgery on scope and scope for neurocystic circus cysts. And in the fourth ventricle cyst, you can. But the only problem is that the flexible scope can actually, you need, if you're going through with a rigid scope along with it, and you need a double vision, you need, the only scope that flexible scope can go in is a GARB scope. The other scopes which are from the Storz company, they are the DEX scope or the LOTA scope. The flexible scope doesn't go through them. You have to create another opening. The GARB scope was good, okay, so that, but the only thing was it was bigger. So you had you can bring it, you can go to the third ventricle and do all the procedures, and then you can put the flexible scope into that, and then you can see a double vision, a PIP.
Yeah. Thank you for your comment.
How useful is sodium fluoride in routine practice? Are you using it in every case or you selected case?
Yeah, I use in selected cases. Our first cases when we used the fluorescing sodium were actually intraventricular hemorrhage. Why? Because that made more easy for us to detect the choroidal plexus. Choroid plexus is the main landmark. You saw the images. Initially, it's a mess, really. It's difficult to understand where you are, okay? Initially, fluorescing sodium was very good tool to detect the choroidal plexus. Once you get to the choroidal plexus of the lateral ventricle, it's like a highway to the Monro foramen. So you just have to follow and you get there. Later on, I didn't use fluorescing sodium in these cases because I got more comfortable moving the ventricle, even with ventricular blood. I still use fluorescing sodium if I have to perform a stoma somewhere because I want to see the vessels more clearly. I use it if I need to do a biopsy for a tumor which is not exophytic, because I want to make sure I'm getting the more enhancing part of the lesion to maximize the possibility for diagnosis for pathologists. So I use in these cases. And recently I am using it, routinely using it for even for ETVs, because we always thought that ETVs are just making a hole in a non-functional area, but it's not completely true. As I showed you, it's not unfunctional. Just we don't know the function, but there is a median eminence, there is a circumventricular organ. So I'm using in these cases to reduce the damage to this circumventricular organ. And my aim now is to try to better define the functions and the functions of this circumventricular organ and the consequences if you damage it. So I think this is a nice area for research.
Yeah, one small comment before Ashish. I don't know how many of you remember that the father of fiber optic is Dr. N.S. Kapani.
Yes.
He is an Indian and who invented how to bend the light. I mean, he's a father of all fiber optic flexible endoscopy. And he is based in California. He was considered for Nobel Prize in 1967 after Harold Hopkins, who was awarded for rigid endoscope. So this fellow could not get his Nobel Prize because of the various reasons. And he has been awarded Padma Vibhushan posthumously this year by Government of India. So many of Indian who are in endoscopy, we should be aware of it. Dr. N.S. Kapani.
Yeah,
Narendra Singh Kapani.
Yeah, we read about.
He was in Ludhiana.
We knew about him, and we have more details about his inventions and all these things. We didn't know that he got Padma Vibhushan. Thank you very much.
He has been awarded.
Very, very nice.
He was actually he could have been a Nobel Prize winner actually.
Yes,
yeah,
I just said that.
The candidate for that. Correct.
Yeah.
Yes, Ashish.
Professor Feletti, thank you for your talk. I routinely use fluorescein for my tumor patients using the microscope, of course. Not tried with the endoscope. 2-3 things I would like to know. I'm curious to know. Have you been doing phenomenon of the monroplasty using your endoscopes? And what about choroid plexus fulguration? Have you tried with your scope? And the last thing I'm curious to know, in patients who have got intraventricular hemorrhage, large intraventricular hemorrhage, but they are put on antiplatelets after coiling. Do you venture to do your endoscopy procedure in those patients?
Yeah, thank you for very, very good questions. About atresia of the foramen of Monro, yes, I performed. I showed one case which we published also in the very first one of the very first slides. I used flexible scope for this kind of problems. Here, probably you can see this atresic foramen of Monro, and we opened foramen. In such cases, it is wise to perform also a septostomy, of course.
Yes.
And through the septostomy, interestingly, with a flexible scope, you can inspect also the contralateral Monro foramen and eventually open it, but not necessary because of the septostomy, of course. Second question was about choroidal plexus coagulation, right?
Yes.
It is possible. I do choroid plexus coagulation if I have to remove a choroid cyst, but not for hydrocephalus, for pediatric hydrocephalus. probably in the last years, it was not so commonly used as a procedure. I know that recently there are publications saying that it can be
interest.
Yeah, but no, I have no experience, not direct experience about that. And about antiplatelet therapy, no, I avoid. If the patient is on antiplatelet therapy because of endovascular therapy, endovascular procedure, I avoid doing this kind of procedure.
Thank you.
That's fine.
Dr.
Okay, last question, maybe Ashish. can I ask one last question, Professor Feletti? This is regarding the alternatives of third ventriculostomy. How many times, or how safe it is to do the, stroma formation in the lamina terminalis using the flexible endoscopy, and how frequently do you do it?
I have never done a fenestration of lamina terminalis with an endoscopic approach. Never had the need. Most often it is possible because I have the space to perform ETV. In a few cases, and we published this experience, hydrocephalus was due to obstruction of the outlets of the fourth ventricle, and the hydrocephalus was so in tension that the space for ETV was not enough, was not considered safe, because the brainstem was pushed against the clivus and the basilar artery tip was very high. So in those cases, we prefer to do Magendiplasty or Luschkaplasty, just to recover the physiological patency of the CSF pathways. But I have never been required to perform a fenestration of the lamina terminalis. It's possible, but there is another circumventricular organ there, the organum vasculosum lamina terminalis. That would be another interesting reason. Yeah.
Thank you very much.
Thank you.
Any other question? Dr. Yadav?
I remember Dr. Axel Pernesky, I asked the same question almost a decade ago regarding opening of the lamina terminalis. And he looked at my face and said, how the hell are you looking for opening the lamina terminalis? Why it is needed when you can open the floor so easily? Why do you want to go to lamina terminalis? Why do you go up? You can go easily floor. It is a triangle. Open up that and that will be the easier thing. So I don't think so. I have also ever taken the lead of going into the lamina terminalis. So all the people have started using that also. Sir.
Yeah, Axel Pernesky is very intelligent neurosurgeon, and I completely agree. Also because if you open the lamina terminalis, I think the CSF flow would not be so effective as the floor of the third ventricle because of the anatomy,
Right.
So probably not so effective.
It's not the same as the prepontine system. I agree with you. Absolutely. So if there is no other question, then shall we conclude this session?
Yes. Thank
Ashish,
you.
please take over. Ashish?
Hello?
Can you hear us, Ashish?
Yeah, I can. Can you hear me?
Yes.
Yes, please go ahead.
Yeah. I was just requesting if Dr. Vikram Karmarkar has got any questions.
Oh, yes. Sorry.
No, I mean, just a small query from Dr. Feletti is what would be the sort of learning curve for moving from rigid endoscopy to a flexible endoscope, in your opinion? How many cases, what kind of cases would you suggest?
Yeah, it's another very good question. I think probably it's not easy for a person who is more familiar with rigid endoscope to move to flexible, mainly because of the quality of vision, which is not so nice. I think it's a matter of getting familiar with such a technique. Probably I would suggest first to perform septostomies. as the first procedure, because you have a shorter route.
Which may disconnect around, so just take over.
More easy to navigate the lateral ventricle, and then second step, before performing exploration of the posterior third ventricle and fourth ventricle. But I have to say that one of the major concerns from the doctors, from the colleagues using just a rigid scope is they are worried that the flexible scope could damage like the fornix or the cerebral aqueduct. But as I showed you, the flexible scope is so flexible and so nicely adapts to the anatomy that you cannot have damage to those structures if you know just a few tips, like when you carry back your endoscope, you have to do exactly the same maneuvers you made when you entered. So when retrieving it, you have to be careful. But if you know that, no damage can be done on the fornix or the cerebral aqueduct.
One has to learn the steering of the flexible endoscope, you know, how it moves.
Yeah.
When you move up, it goes down, up, you know, so that steering has to be learned before one actually takes and make an attempt to taking it from the third to fourth ventricle. The rest of it will not be that difficult, but then initial learning is how to steer those flexible endoscope while you are inside the aqueduct and in the fourth ventricle.
Right, right, sir. Right.
Thank you.
Thank you.
Yes, Vikram, any other question?
No, sir. I am.
All right. Then. Okay, fine. Then I think we conclude this session here. We are already short few minutes. I'll thank you very much, Professor Feletti, and all the speakers who really, presented very nice, made a nice presentation, and which was very informative, and all the panelists who really contributed a lot. I thank you very much. And Mr. Naik.
Yes, sir.
Are you around? Please.
Yes, sir. Yes, sir. Yes, sir. So thank you, audience, for taking your time out from today's day, which was a special day, Valentine Day. So you took your time out for this educative webinar. Thank you very much for that. I would like to thank our speakers, Professor Sarat Chandra, who really curled it like Carlos, taking us from the journey of his bloody surgeries to bloodless surgeries, his 20 years of experience of the surgeries. In this webinar, we had discussed EasyGo technique from Germany, but today we came to know Easy Track surgery invented by Professor Sarat Chandra. Thank you very much for the presentation. And it is always a pleasure to listen to Dr. Professor Yadav, sir, the way he gives step-by-step technique of any topic that he chooses. Professor Feletti, thank you very much for joining us in India. You are dressed for the occasion for Valentine Day, and also Dr. Daljit Singh for the Valentine Day with the color that reflects Valentine Day. Professor Feletti, thank you very much for taking us through your flexible technique, flexible endoscopy techniques. Thanks a lot. Our audience really learned about it. And panelists added their value. Dr. Daljit Singh, thank you so much. Professor Ashish, Suri, Professor Vikram Karmarkar, thank you so much for your value addition. And Sir, Professor Suresh Sankhala, for conceptualizing this fantastic webinar series. Today we conducted the 7th of this series, adding so much of value to the learners, the initial doctors who are going to the learning curve. And Professor Ashish Pathak for coordinating this series extremely well. And thank you very much for giving us this opportunity to carry this wonderful series, which is going on. Today is the 7th, and probably will go on further. So this is Deepak Naik signing off from Health and You. In case any of you have missed this, either as a part or the full webinar, this will be uploaded tomorrow on DigiNeuro channel on YouTube. So please go on the DigiNeuro channel, subscribe it, and you will get this entire webinar and more than 50 webinars of neurosurgery and neurology. So thank you very much. We enjoyed carrying this webinar. So thanks a lot. More than we got 141 attendance today from 4 different countries, 9 of them from abroad. So in spite of surgeries happening, the webinars happening back to back, we are getting good audience. So thank you so much for attending today's webinar and the members and the speakers. Thanks a lot. Signing off. Good night.
Thank you.
Thank you, Deepak. Thank you.
Thank you. Thank you.
Thank you.
Thank you, sir.